Hey everyone, so this is the Chapter 38 Assisting in a General Exam lecture. So again, we're going to work through our lecture map, and this one is several pages long like the last couple have been. I'm trying to make them a little bit bigger so they're a little bit easier to see, so hopefully these are easier to read when you download the PDF from Canvas. So on page 1 we start with the purpose of the general exam. The first reason that physicians typically perform the general exam is to confirm the status of a patient's health. So these general exams are most often done annually. So physical exams generally are done annually for one reason or another. Some of them are done to fulfill a requirement like a physical prior to a school enrollment or a sports physical annually. When my kids were younger and were in school sports, they always had to have a sports physical every year before they could participate in a school sport. Sometimes these general exams, physical exams, are done on a pre-employment basis. So for those of you who are getting ready to go out to your practicums in the fall, you are now preparing to get your physicals done and know that all of those items that you have to check off on that physical form that I gave you have to be evaluated by your physician. So that's another reason why we have patients doing these general physical exams. And then also sometimes too, patients will be advised to have a general physical exam before they start a strenuous or particularly challenging or very different than what is their normal exercise or diet program. So we want to make sure that we have a good understanding of their general baseline health before they start to make any major changes. Even though those changes are positive, it's still good to kind of know where they are starting from. So another reason why we do these general exams is to provide a baseline for vitals. So this gives the physician a reference point to refer back to throughout the year or when the patient is sick. So if we know that the patient's blood pressure usually, anytime they come in the office, is at about a normal range, then when they are ill, it is below normal or above normal. We can look back at the physical exam or their other vital signs patterns and see that that is an abnormal reading for that patient. Likewise, if we know after the general exam that that patient's pulse is a little on the lower side because they exercise a lot and they are very athletic, then that would be their normal baseline for that particular vital. And so that can be referenced also. So where 80 is a normal pulse for somebody, for most patients, if it is a well-conditioned athlete whose pulse normally runs a little bit on the bradycardic side, 80 may be something that the physician would probably raise an eyebrow at if it was sustained for a period of time. So it provides this baseline for vitals for the physician to refer back to. We also have patients in to be diagnosed. So the clinical diagnosis is made up of two things, signs and symptoms. And signs are the objective things that are seen by the practitioner or that are proven through testing. So remember a few weeks back when we were talking about SOAP notes? So there's the subjective, objective, assessment, and plan portion of the SOAP notes. The signs are the objective part. So they are the things that we see or the practitioner sees and or can prove through testing. The symptoms are the subjective information that is supplied by the patient. So it's when they come in and they're like, oh, I've had a stomach ache for 3 days, or I've had diarrhea for a week, or my back has been hurting since I, slept funny 2 weeks ago, or whatever the case may be. So those are symptoms. Signs would be for the backache a sign would be a bulge in the spinal area, like maybe a bulging disc, or if a patient comes in and says, I have had this really bad pain, and you can probably hear Chico barking in the background, so sorry about that. If a patient comes in and they're like, I've had this really bad pain in my back, and I felt very nauseated, and sometimes I have dyspepsia, like heartburn, and I've been throwing up a lot, and I just don't feel really well, and the patient has a sign of jaundice, or they look emaciated, or they look like their pallor is off, like their coloring is off, or whatever the case is, the doctor is going to need both those things that they can see, the signs, and the symptoms that are described by the patient in order to arrive at a correct diagnosis. So they kind of correlate and go hand in hand. A differential diagnosis is when there are two or more possible diagnoses. So this happens a lot with things like headaches, stomach aches. There are a million different things that can cause someone's upset stomach, just like there are a million different things that can cause someone's headaches. And so what the actual diagnosis is for those things has to be made usually by further testing, or be developed, I guess, by further testing and treatments, and kind of an exploration into the symptoms or the signs that were presented during the general exam. And so that's how a differential diagnosis is developed. And then once we have the differential diagnosis or a clinical diagnosis, the prognosis is the forecast of the probable course and outcome of the disorder and the prospects for the recovery. So the prognosis, it basically says, this is what we think is going to happen with this disease or with this illness, and this is how we think you're going to recover from it. So you hear the term prognosis a lot in regards to cancer patients, and when they are talking about the patient was diagnosed with stage 2 cancer, the prognosis is good. So in stage 2 cancer, the cancer has caught pretty early. They can usually eradicate it via surgery and then chemo and possibly radiation, so if necessary. And so the prognosis, or the prospect for that patient recovering from that cancer, is good. Now, if a patient is diagnosed late stage, like stage 4 or 5 cancer, the prognosis will become increasingly less good for them. So if a patient is diagnosed with stage 4 metastatic breast cancer, their prognosis will be much more bleak than a patient who is diagnosed with a stage 2 breast cancer. So that's kind of how it works with the diagnosing and prognosis bit. So your role in a general exam, first you're going to prepare the exam room, and we're going to talk about that in another slide. You're going to conduct the preliminary patient interview. We've already done some of those in class together in our lab time, where you are interviewing each other so that you can then document an accurate patient history. So you want to make sure that you are accurately taking down all of the information from the patient to kind of put together this picture of their history and get that into the chart appropriately. You also want to make sure that the patient is physically and emotionally comfortable. You want to help with the patient positioning. We're going to talk about that more also. And assist the provider during the exam by passing instruments, getting them supplies, supporting the patient as necessary, things like that. Another part of our role in the general exam is largely to communicate the exam's progress, and this is more to the patient than it is the provider, and that again lends to making sure that the patient is both physically and emotionally comfortable. So it's super awkward when you're at the doctor sometimes and you don't really know what's going on and nobody tells you, so you want to make sure that you're communicating the exam progress by saying, We are just finishing up with your reflex testing, and then we're going to move on to the breast exam, or we're just checking your lungs, and then we're going to move on to the reflex testing. So you just little things like that. It's not like you have to be militant and make sure that you are hitting every single aspect, but the important things so that you can ensure the patient or reassure the patient that the exam is moving along, and also that you are keeping the patient informed about what is happening during the exam. While you're doing all of that, you also want to observe the patient for signs of distress so that the provider can stop if necessary, or so that things can be readjusted. It could be that they're laying in an awkward position or that they're uncomfortable. Whatever the case may be, then we can address those things. So the exam room, before I get to that, I'm going to do the safety precautions. So for safety precautions when preparing for the general exam, you want to make sure that you are always following OSHA guidelines. You should do that anyway for every single thing that you're doing in the office. You want to, make sure you're washing your hands, put your gloves on, your masks if necessary. Wear other PPE if it's needed, if you need to put a gown on or, whatever you need to do. Make sure you are discarding biohazard waste properly. That's super important. Always clean and disinfect the exam rooms, and then, of course, sanitize and sterilize equipment after every exam, so after each patient. We never reuse items on patients that have been exposed to bodily fluids, so we want to make sure that we are doing that. And if they are reusable items, we make sure that we sanitize them and use protective sheets over them, or whatever the case may be, to prevent cross-contamination between patients. Okay, so for the exam room, there are guidelines that you should follow when you are preparing the exam room for the next patient. So we sometimes call this turning over the room between patients. So what you want to make sure you are doing for each room turnover between patients, you want to make sure you're getting rid of all the trash, of course. Make sure that any cloth gowns and drapes are put into the laundry bin. I just realized that this laundry looks like bundry, so sorry about that. You want to make sure that any reusable items are put back in place. So if you, if the physician or the provider or anybody took out, the stethoscope and it's the room one, or the thermometer, or anything like that, any reusable items, make sure those are wiped down, sanitized, put back in place. Exam table needs to be in an upright position. The exam table should be cleaned and the paper needs to be changed. Nothing grosses me out more than if I go into an exam room in a doctor's office and I see that the paper is creased, because I know that somebody else's butt has been on that table between mine and whoever was in there last. So or it was the last person's butt. So make sure that you pull that table paper down, rip it off, and you have clean, uncreased table paper on there, because I am sure that I am not the only one who gets freaked out by the thought of potentially dirty table paper. Make sure that the counters are cleaned and wiped down, restock any low supplies, spray air freshener if there are any lingering odors. About this, here's my little caveat about this. So you want to very lightly spray air freshener. Sometimes we have patients that come in and they will smell very strongly of like cigarette smoke, or since we're in California, most oftentimes it's not cigarette smoke, it's other types of smoke. You will have patients that will leave smells behind in the room. And that, people do what they do. We're not here to judge, but those smells can be offensive for the patients that are going to come in after them. So you want to just lightly air freshen around the room, but at the same time be mindful of the fact that you don't know if the patient coming in has any allergies to fragrance, so you don't want to bomb it with air freshener either. If you need to, if you've had a patient in there that has a communicable disease, you want to spray disinfectant spray, usually like Lysol spray or something on the surfaces, and spray it in the air to help kill some germs and minimize. So Lysol spray is usually the choice because not only is it a disinfectant spray, but it also smells good. It can kill lingering odors and help prevent communicable diseases between patients. And then set up for anything that the provider is going to do for the next patient. When it comes to preparing the patient, there are two things you need to be mindful of. The patient may need some emotional preparation. When you are talking to a patient, you should make sure that you are using simple, direct language. Remember that not everybody has been through Medic 150 and 151 course, so not everybody knows their midterm and advanced midterm. And so if you tell somebody that they need to, if you go and ask somebody if they have had emesis, they're not going to know that you are talking about vomiting. Just ask them if they've been throwing up. It's okay. Everybody appreciates that, people in the healthcare field are hopefully well educated, but when you're talking to patients, you need to talk to them like you would talk to your mom or to your aunt, respectfully, but also with easy to understand language. You want to make sure that you are always mindful of the patient's modesty and privacy, and make sure that you're respecting those both. That is a huge deal for multiple reasons. Legality is one, but more importantly, because you as a healthcare worker are tasked with providing care to people in their time of health need. And so your goal should never be to cause the patient any undue harm or any further stress or discomfort. And so ensuring that they can trust you to protect their modesty and to protect their privacy when they are having these exams done that are going to expose parts of their body that they don't want the whole free world to see, can definitely help comfort them and gain their trust in you, to know that you will do your best to be respectful of them. Chaperones are recommended. And usually we recommend same-sex chaperones, and this helps ease anxiety to have another person in the room when the general exam is being done. Again, we're going to get to the steps of the general exam in a couple of pages, but one of them is a breast exam and a genitalia exam. And so it is preferable for a chaperone of the same gender to be in the room for multiple reasons. One, as a security measure for the patient to help them with emotional support and comfort, and two, to protect the dignity of the healthcare providers that are in the room. So it's twofold. It benefits both the patient and the provider that is performing the exam when there is a third party there. And most of the time that we as the medical assistants end up being that third party in the room during a pap smear or during a breast exam or whatever the case may be. Now, I'm going to tell you that I know being in the room while somebody is having those things examined, their genitalia or their breasts examined, probably is awkward and is uncomfortable. And be that as it may, if you are the chaperone in the room, your job is to always pay attention to what is happening, to make sure that there is no misconduct, and also to make sure that the patient is safe. So you cannot look away. And that's just what it is. I mean, I'm not saying you have to stare and be creepy about it, but you need to also make sure that if you were ever called to testify in a court case, that you can testify truthfully about what occurred in that room. You can't do that if you aren't paying attention. All right, so the other thing for prepping the patient is physical prep. So the goal there is to respect the patient's dignity and to make a positive effort to provide a comfortable, considerate atmosphere for the patient. You want to make sure that you provide a gown and privacy for undressing, and always make sure that you are sensitively draping a patient whenever they need to be draped. So if they're having the genitalia exam done, you want to make sure that you drape them fully, usually from the chest all the way down to the waist. And if it's the breast exam, you want to make sure that you've given them enough draping, and always leave them covered until the very last minutes when they have to be examined. Oh my goodness, it's been a long day. Examined, and not leave them exposed unnecessarily. And also, you always need to make sure that anytime you touch the patient or anytime you are draping or anything else, you always need to ask permission to touch them and then explain to them what you are doing. So make sure that you wait and allow them to acknowledge your asking them for permission, grant you that permission, and then make sure you explain to them what you're doing, before you do it, while you're doing it, the whole entire time, so that there's never any question about what it is that you're doing and why you're touching them. Okay, so various exam methods. I know that there are questions on your exam, on your chapter exam for this, so make sure you know these. Inspection is the visual exam. It can be done either with the eyes, or sometimes we use these various tools like scopes or imaging equipment to aid our eyes to inspect various body parts. Auscultation is listening to the body sounds. This is largely done with a stethoscope, so that's pretty much how auscultation happens. I forgot to highlight that one. Palpation is the use of touch. The physician will perceive physical signs by using a tactile sense, a temperature sense, and a kinesthetic sense of position and vibration. So basically, he's going to feel all around on different areas, usually the belly and other tissues, and be able to feel and decide whether or not the underlying structures are normal, or if the temperature is normal, or whatever the case may be. Percussion is tapping to hear sounds. I drew a drum for the percussion thing because I didn't know how to. I tried to draw fingers tapping like 10 times. It didn't work. So then I thought, oh, a drum is a percussion instrument, so that's why there's a drum there, in case you were wondering why that's not a body part. But tapping is, percussion is tapping to hear body sounds. So the body is struck on the surface to emit sounds, and those sounds will then vary in quality according to the underlying tissues. And so you see the doctors do that a lot on the belly, sometimes on the back, sometimes, not often on the chest, but sometimes you'll see them tap. Mensuration. This is not menstruation. I'm just throwing that out there. Mensuration is measuring. One example of that would be vitals, like we measure temperature, we measure pulse, we measure respirations. So anything you measure is mensuration. Ooh. And then lastly, manipulation. I couldn't even think of anything to draw for manipulation, so it doesn't have a picture. But manipulation is moving body parts to determine a joint's range of motion. I thought of one thing to draw and then quickly deemed it inappropriate. So there's no picture for this one. Sorry about that. Okay, so page 3 covers all of the positions, and yeah, they're all on one page. I thought I might have had to go to 2 pages. Oh, excuse me. Let's see. Where do we want to start? So positioning is... There's all these different positions that you need to know. There's also that positioning guide that I have put in Canvas for you that you also need to know. Memorize that thing, because you'll be tested on that for your proficiency. So when we are positioning patients, we need to remember that a symmetrical body is going to be less prone to injury, and that is largely because compensation for the weaker muscles tend to overburden the system of the stronger ones, of the side that the stronger ones are. So we want to make sure that we are positioning patients properly, and as symmetrically as possible, so that there is no overcompensation from the other side, or no further injury to the side that's being overcompensated. Okay, so for each of these positions, you want to make sure that you know what each of them are used for. That information is in your textbook, which you are also supposed to be reading. So make sure you look each of these up and know what they are used for, because those questions are also on your exam. So we start with sitting. Sitting's pretty obvious. It's just sitting. But when the patient is sitting for an exam, you want to check them for symmetry, and also double check and make sure that support isn't needed for them. Sometimes patients will need a pillow behind their lower back if they have back pain while sitting, or whatever the case may be. You want to, supine is the next one, and that is where the patient is lying flat on their back. Prone is lying flat on the stomach. Dorsal recumbent is lying flat on their back with their knees bent, and then flat on their feet flat on the table. The Sims position is where I'm not very good at drawing stick figures, so a little diagram here, if it doesn't make any sense to you, is labeled right leg, right arm, left arm. But the Sims position is where the patient is lying on their left side with their left shoulder placed behind the patient, while their right leg is flexed and placed in front of the left leg. So if you're trying to get a mental image of this, think of sleeping on your side with your leg hiked up. So if you if you're laying on your left side asleep with your torso kind of bent forward and your arms up, under your pillow, and then your right leg up. That's kind of what that would look like. The semi-foulers is lying on the back with the head raised to a 45-degree angle. Knee chest is from a prone position, so from lying flat on the stomach, you would separate the knees and then bring them up to the chest, so raising the butt up in the air. The knee elbow is essentially the same thing as the knee chest, except for the patient is resting on their elbows instead of their chest, which tends to be a little bit more comfortable for patients, because having your chest flat on the exam table and your butt up in the air is kind of awkward and difficult for some patients. So the knee elbow sometimes is a suitable alternative. So the thing about the knee chest and the knee elbow that you need to remember is that both of these tend to be pretty embarrassing to patients to be in that position. So if you have to put a patient in that position during the general exam, you want to make sure that you're using a drape. If possible, a fenestrated drape. And if you don't know what a fenestrated drape is, it is a drape that has a hole cut out of it someplace, usually in the middle. And so by using that fenestrated drape, it keeps the whole rest of the patient's body covered, and then there's only a hole exposing the area that is going to be examined. If we don't have fenestrated drapes, then keep them draped as long as possible until their genitalia or their rectum or whatever it is that's being examined has to be examined and exposed. So the goal there is to, of course, preserve the patient's dignity and privacy as much as possible. So the lithotomy position, if you've ever had a pap smear, you have been in the lithotomy position, or had a baby, you have been in the lithotomy position. It is lying flat on the back with knees bent and feet in stirrups. You also want to make sure that you're protecting the patient's privacy in this position as well by appropriately draping the patient from the breasts all the way down to the ankles. So that way, everything can stay covered until it is examined. The Trendelenburg is used when a patient is lightheaded or the patient faints. The patient is placed on their back, and then the head is lowered several inches below the heart, and that ends up promoting backwards blood flow to the brain. So you know how when you were a kid, if you stand on your head for too long or you bend over for too long, all the blood rushes to the top of your head? Well, that's kind of the point of this Trendelenburg positioning, is to cause all the blood to rush backwards to your head. And so when a patient faints, you want to get the blood flow back up to the brain, and this position helps with that. And then the last one, the proctologic position, is also known as the jackknife. It is an alternative for Sims and the knee-chest position. And so basically in this position, the patient stands next to the exam table, bends at the waist, bends over the table, puts their chest on the table, and then the doctor is able to examine the patient's rectum that way. Okay, so special considerations when patients are having a general physical exam. Patients from a different culture may not be familiar with medical exam and won't know what to expect. So it's important to make sure, again, that you are telling them step by step what's going to happen and what is happening to them. Some cultures value modesty and much more than perhaps ours does, and they may have a greater need for extra privacy, so it is our job to afford them that when possible. Physical disabilities are also another special consideration. Patients with physical disabilities can vary in their ability to move from place to place, so they may require a little extra help getting undressed or disrobed, getting on and off the exam table, and then also getting into some positions. So just some things to note there. What I did put down here as a little disclaimer is to always be mindful of your nonverbal communication when you are assisting and with patients who may need a little extra help. Your facial expressions, etc., can make the patient even more uncomfortable. So you definitely need to make sure that all of your filters are on, because the goal, again, is to be as accommodating as possible and make the patient feel respected and comfortable while they are there. All right, so all of the steps, the components of a general exam. Okay, so the first thing that providers will look at is the patient's general appearance. That's their hair, their skin, their nails. Skin is an overall indicator for general health. So if there's a lot of rashes, lesions, bumps, bruising, things like that, it's usually a pretty good indicator that there's something going on that shouldn't be. And so since your skin is your largest organ, providers will often use that as an indicator for a patient's overall general health. Head and neck are checked for symmetry and range of motion. The eyes and ears are checked for diseases or abnormalities. Perla is where we check the pupils, or the provider will check the pupils for equal round reactivity to light and accommodation to make sure that they are tracking and the pupils can follow movement. Nose and sinuses, the provider will check nasal mucosa for discharge, any lesions, swelling, inflammation, or obstructions or blockages. The mouth and throat, sometimes it's better to use a tongue depressor when checking the mouth to hold the tongue down, but the physician will take a look around in there and check for diseases and abnormalities there as well. The chest and lungs, the patient will be asked to breathe deeply to check for signs of dizziness. If the patient is dizzy, then they may be hyperventilating. The chest is going to be checked for shape and symmetry and their postural position. If the patient has kyphosis, that is humpback, we often see that in elderly patients where they start to hunch over. Heart and chest are checked as well. The heart is checked for rhythm, rate, intensity, and pitch. Chest exams also include a breast exam for both men and women. The female breast exam is a little bit more invasive than the male breast exam, but both to check the tissues for signs of cancer or lesions or anything. The abdomen will be examined too, and it is divided into 4 quadrants. When it is examined, there's the left upper, left lower, and right lower quadrant. Genitalia. So when a patient's genitalia is being examined, obviously they may be anxious about that. Nobody really likes to have their private parts like out in public. Even though they are in a private room with a physician, it's still somebody that they normally wouldn't expose their genitalia to. So it's anxiety inducing, it's awkward, it's uncomfortable, and even though most providers have seen more genitalia than their patients probably care to know about, it doesn't make it any less awkward and weird for the patient. So your job is to help try to ease that anxiety, and also make sure that if you are not the chaperone, that there is a chaperone in there of the same gender as the patient when the genitalia are examined. And we talked about that a little bit ago about why that is necessary. The rectal exam is also known as the digital exam, and that is performed with a gloved finger that is lubricated. So the patient, usually they'll do that right after the during the genitalia exam. They'll slip a lubricated finger into the rectum. For men, this is to examine their prostate gland, to make sure that there is no enlargement, which would be indicative of prostate cancer. For women, it is to sometimes check the posterior side of the uterus or other tissues, and at any rate, most people aren't prepared for it, and a lot of providers they'll just say quick finger and then there it goes. And so usually it's in and out and done before the patient even knows, but it is a little bit of a shock. So the thing is to make sure that you're trying to comfort the patient and walk them through what is happening. And then afterwards, you want to make sure that you give the patient a tissue to wipe the extra lubricant off when the exam is over. The musculoskeletal portion of the physical checks the overall range of motion of all of the limbs and the strength of various muscle groups. On kids, this portion also checks for spinal curvature. That would be an indicator for scoliosis. And then lastly, the neurological portion assesses functions of the patient's reflexes, their mental and emotional states, and then also their sensory and motor abilities. So the last page talks about what happens after the exam. If there are additional tests and procedures, sometimes those are needed, and they could include things most oftentimes like blood samples being drawn to run labs on. Sometimes it's diagnostic testing, like an X-ray, an ultrasound, a pulmonary function test, an EKG, things like that. Also, too, sometimes they may need therapy sessions. Those could be mental health therapy sessions, but they also could be physical therapy sessions. They could be occupational therapy sessions, things like that. Patient education. The patient may need further education about various risk factors for disease and how the behaviors that they currently possess may be increasing their risk factor for a disease, and or the genetic predispositions that they are currently subjected to may be a risk factor for disease as well. They may also need referrals to other resources. For instance, if a patient is newly diagnosed as diabetic during their general exam, then they may need resources, referrals to a dietitian or nutritionist, smoking cessation hotline, or things like that. For follow-up care, follow-up needs will vary by patient. They include scheduling follow-up visits for both inside the office and sometimes those referral visits for outside of the office. Follow-up care also includes planning for help that may be needed at home, so for home care. And then also, lastly, it includes linking patients to community resources when those are needed as well. So that's pretty much it for the general physical exam. If you have questions, let me know in class, and I will do my best to answer them for you.